Well, it gives me great pleasure to introduce the Thomas Orr Memorial Lectureship this year. I had the privilege of picking Krista Kaups from UCSF Fresno to give this lecture. Dr. Kaups is a professor of clinical surgery at UCSF Fresno. She's the director of surgical critical care there. She's obviously trauma and critical care trained. We have some ties in the sense that we're both University of Illinois College of Medicine graduates, mine campus being Peoria, hers being Chicago. And another tie when she saw my laptop here a couple years ago, because she's a graduate of Bethel in St. Paul, Minnesota, and that's where my oldest daughter will graduate from next week. That's not why I picked her, but I picked her because of her contributions to the field and to the Southwestern. And she's obviously been instrumental in a variety of societies, including this one, and many of the trauma and critical care societies. She even has a master's in public health from the London School of Hygiene and Tropical Medicine. And she is also on the ACS Committee on Trauma, the ACS Health Policy Advisory Group. And I'll let you finish reading the rest of her bio yourself so that she has the majority of this time to share with us the all intriguing title of The ICU, Stop, Look, and Listen. Dr. Kaups.
All right. Set a timer, see what we're up to, right? So, good morning. I'm so very, very honored to be here. I'm also hoping sincerely this is my clicker. And we'll go from that. I have nothing to disclose. And, you know, when you talk about things, it's always good to know who it is that you're talking about. And so when I found out it was the Orr Lectureship, I had to look it up in the on the website. And the thing that really stuck out to me there described Dr. Orr's achievements, his education. He was a chair. He served in the First World War. He helped found the American Board of Surgery, as well as the Southwestern Surgical Congress, and was the second president. But his patients and colleagues always remembered him as someone who always had time to talk and listen. So, as our esteemed president mentioned, he sent me an email and asked me if I'd be willing to give this lecture, and I was flabbergasted and very flattered, and really wasn't sure he'd had the right person first, honestly. And I said, well, what kind of a topic are you thinking of? And he said, well, let me know what your thoughts are on a critical care topic. So I came up with various things that included some thoughts on critical care, what we thought we knew and what we know now, learning from our mistakes, stop, drop, and roll, but that's already been done, so pass on that. And what about something about SARS-CoV-2? And I quickly decided that wasn't something I wanted to talk about because I think we've all heard enough about COVID, but we will hear a little bit about that as well. So I came up with the thought of thinking about what's going on in the ICUs. Just as a matter of statistics, there's about 80,000 staffed ICU beds in the US, and this was a recent estimate. There are 94,000 beds, about 14% of all hospital beds in the United States, more than 5 million people. And the problem is, of course, it's tough to, you'd think there'd be up-to-date data, but about 5 million is the estimate for an annual number of patients admitted to ICUs in the United States. For various reasons, it's a heterogeneous population, but all share the need for assessment and a greater need for technological support than patients who go to quote unquote regular beds. It's also known as the expensive scare unit. And we know that costs in the ICU have gone up from $56 billion to $108 billion annually. It's about 0.7% of the entire United States gross domestic product. Mortality rates vary depending on what you're in the ICU for, and depends on what else is going on. And We also know that anybody who's admitted to the ICU, if you do age comparisons, for the next 10 years, their mortality rates are going to be higher. Of course, you could argue, well, they're in the ICU to start with, but we're paying an awful lot of money for some really sick patients and maybe who aren't doing as well as they should. So let's stop and think about that. Well, yeah, COVID did come into it as well. And, I think this audience knows well, when we look at things, and it's interesting because that's 2020 data, although the graph is up to date. In fact, with April at the far side there, it's looking at the teal is ICU beds, the whatever color, Adobe color, is COVID patients in ICU beds. And what you see, although the number of COVID patients is lower, but what you see is actually over the last 2 years, we've had a steady trend in the number of patients in the ICUs despite COVID or because of COVID or in addition to COVID. And we know as we look at COVID patients that if they end up in the ICU, about a third of them did. And again, this is 2020 data. It couldn't get, because many states don't even submit ICU or hospital data anymore. So these are best guesses. We know that things get expensive. Cost is 5 days. If it goes up to mechanical ventilation, time goes up even farther. If we look at ICU usage worldwide, we see that we've got that. Here we go. And I'm going to go back for a quick second. What we see, that thing that looks like a bunch of peaks there, is ICU data worldwide from the few places that you can get data, US and some of the European countries. And when we look at, that's ICU usage per 100 million population. And fortunately, we're all down on the low side now. So I think, if anything, Dr. Kathari's lecture yesterday, at least for most of us like a story. We like to think about things. We like to hear stories. So I'll tell you a little bit about my family. My parents escaped from Estonia. They grew up there and they escaped in the middle or towards the end of the Second World War. And there's a little map there of Northern Europe, just to put a little perspective if somebody's going, where is that place? And when I was growing up, it always seemed like some kind of place that didn't really exist. It was occupied by the Soviets for the next 55 years. And in September 1943, my dad, who was just a few months past his 17th birthday, at a very draftable age, looked at his prospects and said, well, I could go with the Germans and go there. The Soviets are conscripting as well. That doesn't seem very good either. I could stay here and see what happens, which didn't seem very promising. And so he, with a significant number of young men over a year or two, took a boat at night and went to Finland and served as volunteers in the Finnish army. And he went to officers training. That's a picture of him there, looking all of 17 years and 3 months old. He participated in tank and explosive training, and his description of that is really quite good. They'd have various things they shot off, and you can imagine these young teenagers like shooting really noisy, loud things. I mean, again, it was serious and it was a real deal because there was a war going on and the Russians were invading, but he did that. And it's a whole longer story that I'm not going to go into now, but both of my parents eventually, with their families, escaped to Sweden and came to the United States. So by background, this is April of 2021, actually literally almost exactly a year ago. And Dad, for his services then, and it's just recognition of that, actually received a medal from the government of Finland. The defense attaché from the embassy came to my parents' home for the day to award him the medal. Dad is in the back row, looking quite short and quite furry in his group there. But so that was a year ago. So we'll go up to, and my dad is a guy who's always had sayings. He'd always, in college, when I was complaining about my, whatever it was, PChem course, he'd be like, keep a stiff upper lip, keep at it. And of course, when we're doing particularly well, he would say, now you're cooking with gasoline, which is really a very troubling thought if you think about it. And if you were particularly self-congratulatory, he would observe that even a blind squirrel will find a nut now and then. The other thing that was always a little puzzling is I have sisters. I don't have brothers. And I can remember sitting around the dinner table or lunch table, and he would say, eat up your whatever it is, girls. It'll put hair on your chest. And you can imagine that, ew, Dad, that's not what we're after. But other important things include the fact that there is no shame in hard work. And the thing that he always told me when I was a little girl was, don't take yourself so seriously. And it would frustrate me no end because I had no idea what that meant. I really didn't. I'd say, well, what does that mean? I'd be like, don't take yourself so seriously. And I think it's a good admonition to all of us, and we'll see it come into play a little bit later. So anyway, we'll come up to January of this year. Dad hasn't been feeling well for a week or so. By now, Mom and Dad have been exported to California, and they're near my sisters. He wakes up from his afternoon nap and he's gasping for air, his right arm weakness. Promptly goes to the ED or gets taken to the ED. He's a 95-year-old man, hard of hearing. Remember those explosives? I think it had something to do with it. Oxygen stats are in the 70s. And he's oriented to person and date, but he's really not sure where he is. His CRP, for those who care, is 64. His BNP is 800. They put him on high flow nasal cannula, 70 liters at 70%. And oh, of course, we've got no visitors. So I'm having conversations because I'm the designated medical person with the hospitalist about what should be done. And talking about, no, we don't want defibrillation. No, we're not going to do CPR. And oh gosh, no, he's not going to do really well if we intubate him. So I guess we won't do that. So we've got Dad in the hospital. And so as we look at it, this is part of stop, look, and listen. And by way of saying is when I started medical school, my stated goal was to become a family practitioner. I was actually at University of Illinois, Rockford, not Chicago, interestingly enough. So I was going to be a family practitioner, and this is my med school graduation picture. Certainly have gone in a very different direction from that. You'll also see that was the time when perms were a thing. So went through medical school, I was trying to find a picture from my ID badge from fellowship, which is existing somewhere in a deep closet at my house. But this is my picture when I first became attending, and looked at what are some of the things my attendings told me to do. This is the stop. What did we know? What did we do? So truths that we've learned about ICU care. At the time, we were told more fluid is better. Leave a fed. Ooh, that was not good stuff. Hemoglobin. I can remember being told that you can't take the patient to the operating room for anything unless their hemoglobin's at least 10. Beta blockers are a good thing. Got to work on some glucose control. And we'll talk about some of them. For your relief, we're not going to talk about all of them, just in case you're concerned. We'll go through a few of these things, but I'm not going to inflict all that on you. So let's talk about more fluid is better. I was a fellow, it was the era of the supranormal or optimal parameters for resuscitation. There's a few people here, I see some nods. Yeah, Dr. Shoemaker had published this. The idea was if we could only get enough oxygen delivery going, we would take care of the oxygen debt, and we would take care of patients. And so we were going for optimal values, cardiac index more than 4.5 liters per minute, oxygen delivery greater than 600 ml per minute. We were, if you were a good fellow, that's what you were doing. If you were a good attending, you had your PA catheter, you were calculating values and you were working on that. And basically we did that with large volumes of fluid. And as we did that, we were hurting our patients. I can vividly remember patients we took care of who we were giving them large volumes of fluid. We're 10 liters in and gosh, they're not making urine, and gosh, we're having troubles ventilating them. But I guess they must need more fluids because they're not making urine. So we'll just keep on giving them fluid. And we didn't know about abdominal compartment syndrome. We didn't really realize. And so when somebody finally stopped to think about what we were doing, we realized that as we looked at it, patients were not doing better with supranormal values, that there was no benefit. If patients could achieve those on their own, great, but for us to try and put them into that. What about the PA catheter? Well, there's a study that came out that was called the cult of the PA catheter. And we looked at that and started realizing that maybe what we wanted to do wasn't that. And pulmonary artery catheters were not helpful. So in general, now we know that fluid responsiveness is most effectively evaluated using dynamic indices and any manner of them, whether it's a systolic pressure variation, whether it's a pulse pressure variation, a stroke volume variation, but looking at what's actually going on with the patient and trying to, and this is not a lecture about resuscitation, but looking at what's actually going on with the patient rather than trying to define what needs to happen. We made a right turn. Levofed. Levofed was the thing that you threw on last shortly before you either gave up or coded the patient. And then we called it leave them dead. Well, interestingly enough, dopamine was what we started with. And as people started looking at it, we said, gee, Levofed, you know what? That's not so good. The dopamine's giving people arrhythmias. It doesn't work as well. And now when we look at large numbers of studies, norepinephrine, aka Levofed, is the preferred vasopressor for the patient in septic shock, and would argue for other kinds of shock as well. So two things that we thought we knew that we don't. Stop. I can remember being told that, we couldn't take this elective cholecystectomy patient to the OR because their hemoglobin was less than 10. Well, for all of these things where you look at, we actually have strong recommendations, actual strong, not like, hi, this might work out. One of them is for the hemodynamically stable ICU patient, including patients with septic shock who are not actively bleeding. Thresholds of 7 grams per deciliter are safe. And all the randomized controlled trials confirm that patients who we went for the lower threshold received less blood. And guess what? There's a blood shortage on, so this is good. And they actually had did no worse in the way of mortality. And so now as we think about things, we have to evaluate where we are. There was no difference in mortality. If we look at cardiac patients, so the second group that had strong recommendations were the cardiac patients, and they did well at 7.5 as well. And again, we're not going to go into all the details. So that threshold went out as well. Tight glucose control is essential, or maybe a little bit of sugar won't hurt them. So hyperglycemia is really common in the ICU, and it has bad effects. When you look at retrospective things, we know it makes infections worse. We know that it'll increase in-hospital mortality, all of those things. And so 20 years ago, the Vandenberg study came out looking at all those things, said, hey, how about some tight glucose control? Let's keep the glucose between 80 and 110. And you know what? When we did that, great, patients actually did better. And we all said, hey, this is terrific. It's relatively inexpensive. We can do this. It'll reduce mortality. How cool is that? So let's do that. Well, what we quickly discovered as other groups started looking at, the Nice Sugar trial came out, big collaboration, and said, we've got our tight glucose people, the 81s to 110s. We've got conventional glucose. We'll just keep it less than 180. And what they found is that 90 days, all the people who had the tight control were more likely to have died, especially of cardiovascular causes. They were more likely to have had hypoglycemia, and there was no benefit at all. So a lot of extra hard work for that, but without any benefit. And when we look at it, hyperglycemia is bad, but hypoglycemia in the 70 to 80 range is bad for people as well. So the worse the hypoglycemia, the greater the mortality rate. So, it's not just there's no freebie on that. The greater the number of events, the worse that people do. So what do we try to do? Current recommendations now are we try to keep a range of 140 to 180. Surviving sepsis says less than 180. There's some special populations, and I'm particularly interested in trauma patients. And they did a study comparing 3 kinds of ranges. Basically, the story is that tight or moderate actually did well or better. And, if you did the 80 to 120 or even up to a little bit to 140, they had similar outcomes. So it's avoiding the badness, taking care of the problems. Steroids. Oh, there's another thing that we all knew about. They're good, they're bad, they're good. What are we doing with them? Well, based on some preclinical studies, the thought was that high dose steroids would be really effective for treating the patient with septic shock. And there were 50 or more human trials tried with methylprednisolone. Doses were about 30 to 120 milligrams per kilogram per day. All right, not just milligrams, mgs per kg. And I remember growing up on the gram of Medrol for the patient you thought was having septic shock. Bad news, patients did poorly, to use the phrase. And in fact, if you look at the graph over there, if you see it at the plot, is on the right-hand side is favors the control group, and you can see all but one study are all in favoring the control group. There's a one outlier where favors steroids. If you look at the black bar at the bottom, don't give the high dose steroids. All right, so steroids are out, threw those out. Oh, but wait, okay, well, maybe we should give them for traumatic brain injury, 10 of Decadron. No, that was bad too. Oh, high dose methylprednisolone for spinal cord injury. Yes, there's another thing. No, as we looked at it, there's no benefit and there are more complications. So we said, okay, let's put the steroids away because those aren't helping us. Well, lo and behold, 10 years ago or so, we've now come back to that. And the audience who's taking care of septic patients says, you know what? We know that septic patients have relative adrenal insufficiency that occurs. And so if we try and replace what's a physiologic dose, maybe that will be helpful. And as we look at the graph again in the right lower quadrant, oh goodness, the right side, you can see that there is benefit to that as you look at the favors the steroids and in terms of outcomes there. So vasopressor dependent septic shock. Now we're back on the good, bad, good for steroids. I don't know if in 5 years somebody else will be going, oh, we're back to bad. So interesting. So stop what we're doing, think about it. Keeping patients completely sedated is essential. Nobody wants to remember their time in the ICU. Well, I'll get to that in a little bit, but sedation without monitoring and without titration contributes to prolonged mechanical ventilation, increases in pneumonia, ICU and hospital length of stay, development of delirium, and has long-term effects. So that's not good either. Oh my gosh. So I wondered what I learned in fellowship that was useful. And oh, by the way, one of the last things that we've all been told is that your major healthcare expenditure is in the last 3, 6, 9, 12 months of life. Interestingly enough, if you look at, you may not be able to see the captions. On the left-hand side is healthcare spending in 8 countries and Quebec. I don't know if Quebec was like being its own country, with all due respect, and the US which was at the bottom of the ranking. On the right-hand side is the last 3 years of life. And what we really see is it's not the last 12 months, it's the last 3 years as people have chronic illnesses, as we're able to look at that. And so really should give us pause to say, okay, looking at the big picture and thinking about that, but not the last 12, it's the last 3 years. All right. So look, stop, look, what can we look at? What can we learn? So this is, I borrowed this from a friend of mine because I just thought it was so entertaining. He's actually a pulmonologist, but you start off with this new promising therapy. There's some initial excitement. There's some animal trials. It kind of hits the media, then it kind of comes up, and then there's kind of general use. And then we go to, it becomes standard treatment. And then we kind of start fading off. There's some questionable studies and there's some bad effects. And then we kind of go down again and we kind of had some long-term discussion. And at the far side, unfortunately got cut off. It's, you know, old surgeons telling their juniors what they did when they were young. So it's the inevitable curve of picking any therapy. And you wonder now what it is that we're going to be doing that in a few years we'll say, yeah, well, we were on the wrong side of the curve for that one. So something I think we should evaluate, because we are big, we like to talk about evidence-based medicine. What's the evidence for that? What's the p-value, right? And in fact, one of the articles I looked at talked about p-hacking, which is, You wonder what that is? Well, it's kind of mercilessly torturing your data till it yields some positive p-value. I have to confess, I've been guilty of that in the past. Hash it through. Well, great, it's significant. Yeah. So what we probably should be thinking about as we look at that is the fragility index. It has nothing to do with ICU patients. It's a statistical idea. It's the minimum number of patients whose status would have to change from a non-event to an event that makes a statistically significant, we'll talk about it, make it a little more clear, significant result into a non-significant result. If you have smaller numbers, if you have group A and group B, and group B is your treatment, well, if you had one less patient who had a positive outcome and your significance gets lost, that's a pretty fragile finding. So if you have a large fragility index, it indicates that you've got many patients responsible for that result. If you have a small fragility index, it says the thing relies on only a few patients. Yeah, okay, all well and good. Let's think about this some more. So number of patients responsible, use it for binary or dichotomous data. You can't use it for continuous things, like you can't use it for age. It's either like died, lived, you know, whatever, extubated, intubated. Use a Fisher exact t-test, and I am not a statistical, like knowledgeable person, so don't, you know, if I can get this, we all can. You also have to think about, so if we use that example that's over on the right-hand side, if we have, say we have a therapy group and a control group, and they each have 1,000 patients in them, so they're pretty well matched. If there are 30 in the therapy group who have hospital mortality, that's 3%. If there's 50 in the control group who have, that's 5%. So far, so good. Everybody with me? Bobbleheads nod, please. Yeah, okay. P-value is 0.03. Hey, cool, this therapy must be really good. It's working, it's 0.03. Well, if we look at it from, and it basically what you do is you sort of incrementally take out 1, take out 2, till you get to that. So by the time you take, say, if you say theoretically there were 48 patients in the control group, would be 4.8%. That gets you a p-value of 0.055, which is not statistically significant. Your fragility index, because you've removed exactly 2 patients, is 2, not a very big number. And it's a measure of the robustness of the outcome. If you think about all the studies that we look at, if you think about where you've lost more to follow up is greater than the fragility index, you have to wonder about the reliability of that data. So just to look at this a little farther, this came out of critical care medicine a couple of years ago. The first group, the dark black, is 166 randomized controlled trials looking at anesthesia and critical care interventions. The median fragility index was 3. There's another, the next line over is almost 400 studies that were in high impact factor medical journals. New England Journal, JAMA, not the Journal of Irreproducible Results. Median fragility index was a little better. It was 8. 40, just, we don't have any, I don't think we've got any orthopedic surgeons here, but 40 studies in spine surgery, fragility index was 2. And if we look at another critical care one, 2 again. If you look at the vast majority of studies had fragility indexes of less than 10. If you look at your, one of your treatment groups, you're having to make changes, you do that. So that's a little discouraging for some of the literature that we look at, but should encourage us to look at that. And again, fragility index isn't that hard to figure. And we need to be thinking about that, is how robust are these studies? Are we basing what we do? And when they've looked at it for critical care, there's only a few treatments that are actually hold up and are robust. Prone ventilation, some of the non-invasive ventilation, tranexamic acid for some of the treatment of hemorrhage. There's a lot of stuff we do that we do without data. In fact, I'll just throw this in, obligatory COVID slide. If you want something that has a little bit of robustness, if we look at COVID-19 infections, looking at vaccine versus placebo, fragility index of 139. So way out on the scale. That data is pretty good, everybody. Kind of exciting. It's nice to have something that's a little more robust. So listen, the final part, stop, look, and listen. What have we learned? I mentioned this already. but we were talking about care in the ICU. And I think Tom Schruppel referred to talking about vent bundles. Well, we've talked about an A, B, C, D, E, F bundle, where we are trying to think about, we've been working on for the last number of years, how we take care of patients, assessing patients, how we manage pain and analgesia, thinking about letting patients wake up, doing breathing trials and stopping sedation, thinking of how our choices for analgesia and sedation, delirium. I'll talk about that in just a minute. Early mobility and exercise, getting people moving, family engagement and empowerment. Well, it's kind of gone by the wayside this last couple of years, hasn't it? Oh my goodness. So if the complete bundle is performed, if you can do all these things, which are not huge interventions, this isn't the razzle-dazzle drug of the week, it isn't whatever it is, but if the complete bundle is actually done, you have a lower likelihood of death, you have a increased chance of not requiring mechanical ventilation, less coma, less delirium, less use of restraints, less ICU readmission, and you have a lower likelihood of going someplace other than home when you come out of the ICU. All good things. So I'm going to talk about delirium for a quick minute, because we always thought that was just part of, sundowning. It's the ICU, it's what happens. Disturbance in attention and awareness happens rapidly, hours to days. The thing that most of us don't realize, if you had to describe the patient with delirium and we were all going to do, acting, I think we'd describe the agitated patient trying to get out of bed, but you actually may have the patient who's hypoactive, who's unresponsive. And the estimate is that about 80% of our patients are going to have delirium, mostly in the ICU, but can happen other places as well. Strong predictor of all kinds of bad things. Higher mortality, longer stays, all sorts of bad things. And the other thing that's, actually I'm going to flip back. The other thing that I need to mention about delirium is we say, well, okay, so it happens in the ICU, it goes away, et cetera, et cetera. And that was always my thought. Well, as they've looked now, examining patients, evaluating patients who have been discharged from the ICU, from the hospital, looking at patients at 6 months, patients have findings that are similar to patients with dementia. At a year, patients have findings similar to patients who've had traumatic brain injury, loss of ability to concentrate, loss of focus, loss of executive function. And it's like, great, we're not doing good things for our patients. So delirium is a great thing to avoid. Risk factors, just about anything. It's like being in the ICU is a risk factor. Blood pressure, anemia, sepsis, you name it. Benzodiazepines are certainly something we've gotten away from using. Mean number of risk factors, identified risk factors in one study was 11. Like, you don't have a chance, with a range of 3 to 17. Of all the things that we've tried, the only thing that actually seems to have decrease in duration is getting people up and moving there, but we've got no meds to prevent it. So if we can, or to stop it, to put it in its tracks, we treat it. But so delirium is another thing that we need to stop and listen about. So one of the other things about the ICU is that the ICU kind of has its own culture. And I lifted this title. It was from an article that came out in the British Medical Journal, end of last year. And it talks about ICU slang can add color and humor, hence the spelling, British Medical Journal, and nuance to professional interactions and may reinforce group cohesion. They talk about a bridge too far, escalating the use of support to a point where the burden on the patient outweighs the benefits. We talk about a proline deficiency. Yep, patient who needs to go to the ER because they've got a proline deficiency. Or we talk about the patient didn't do well. Boy, didn't they do well. They're a little bit in shock. Yeah, okay. It's been a little busy on the unit, means that every nurse has been wiped out. We've wiped out the blood bank, and there's carnage in the halls. And they'll do well until they don't. So if you think about it, there's all kinds of expressions. I think there's a number of residents here. Most of the residents are leery of saying, hey, it's going to be a quiet night, right? Yeah, okay. So all of those things. So that culture that we have in the ICU. So What is the ICU? It's the expensive scare unit. But in texting, if you say, I see you, it means I see you. And that should be our goal. Not just to see our patients, but also their families and all of our colleagues. The last 2 years have been really difficult and devastating in many, many ways. We've had to make decisions, had to do things that we never anticipated, at least in our well-supplied, resource-rich country. At our hospital, we were at a stage that we developed triage standards of care, where we actually got to the stage that we thought we're going to have to decide who's going to get ICU care or not. You know, we've only got so many staff. We all thought it was going to be ICU beds first. Then we thought it was going to be ventilators, that was going to be the shortage. We even actually had one of our RTs rig up a thing so we could put 2 patients on 1 ventilator. Well, it turned out it wasn't the issue, it was staffing. We're down to people again. And we got to a stage where we thought we were going to have to very seriously figure out the patient who was not going to benefit from ICU care and was not going to be offered ICU care to the patient who was most likely to benefit. And we went to the stage of having triage officers, like people who were trained, and we had Epic set up to do those things. So we need to, especially in light of the last 2 years, really look at each other. Maybe we're all battered and bruised too. And ask for help when you need it. When you're on that raft and the riptide is going by, you don't have to be in the OR. It's okay to ask for help otherwise. Look at other people and realize where they're coming from. So listen, talk to patients, talk to your colleagues, talk to the staff, listen. So following on, I started a story and I left you all hanging, didn't I? So story of my dad. Well, he didn't echo with that BNP of 800. His ejection fraction was 60%, which isn't shabby for a 95-year-old. COVID test was negative ×3, but he was confused and needing restraints. He would get him on FaceTime and he would tell us that he had to go to Norway to sell potatoes. It's my dad, who's been an engineer his whole life and has eaten probably, tons of potatoes, but has never sold a potato in his life. He was insistent that he had to go, so he ended up in restraints. There were other places he had to go as well. But the remarkable thing was that by a week, he was weaned down to 2 liters of nasal cannula oxygen. MRI showed that he had some small posterior strokes. So he had some troubles with dizziness. Oh, and by the way, during this time, he had no visitors in the hospital. So every day we'd call his nurses and say, you have our permission to yell at him so he can hear you. And after 2 weeks, he was transferred to rehab. And after about a week there, I was talking to him on the phone. No, I'm sorry, I was yelling at him on the phone. Because he also has a bad habit of saying what he thinks you thought you were asking for, so which isn't always the same thing. And he said, I need to know the address of this place. And I said, well, you're actually pretty close. You're a couple of blocks from my sister's house, from my sister Katie's house. No, I need to know the address. But why? Well, it turned out he thought he would need to get his mail forwarded there because he thought that's where he's going to be living from now on. And he still couldn't quite understand why nobody from the family had come to see him after 3 weeks. He was, he did. So we kept saying, Dad, it's COVID, it's COVID. And so to continue further, he was there another week. And my sister then she got designated as an essential visitor. So the far left is the first day she got to go see him, gowned and masked and all that. And when he realized he hadn't been forgotten, he and my mom are actually now staying at my sister's house. That's one of the grandkids. They're having a little Scrabble game. And the last picture was taken last Sunday as they're what we call, I don't even know the word in English, but it's an Easter egg bashing before they went to church with my sister and her family. My dad's still on his 2 liters nasal cannula, but that was the ICU story of that. So stop, look, and listen. Be curious. Wonder why something is happening. Look, don't take for granted what we're doing. Look, be willing to examine it. Is there data, or is it because we've always done it that way? And listen to all the people that you work with. Thank you very much.
Thank you so much for that.